Good evening, everyone.
Good
I,
evening.
Ritika Jaiswal. Good evening. I, Ritika Jaiswal, on behalf of Concord Biotech, it's my extreme pleasure to extend a warm welcome to all the participants. Concord Biotech is a global biotechnology leader in immunosuppressants with strong capabilities in the manufacturing of high quality APIs and finished formulations. With the presence of more than 70 plus countries, we remain committed to delivering excellence across key therapeutic areas, including rheumatology, immunology, transplantation, and nephrology, by a patient centric approach. So it's once again our privilege to introduce our esteemed speaker for the today's webinar, Dr. Vish Prakash Tiwari.
Thank you.
A
Thank
very,
you.
wa- a very warm welcome to you, sir. Uh, Dr. Vish Prakash Tiwari, he is a renowned rheumatologist based at Indresh Hospital, Dehradun. And a very warm welcome to you, sir. And we are extremely very glad and thankful to you for initiating this academic series. And today we are we are ongoing our fourth session of this series. So a very thanks from all the on behalf of all the participants, and we are truly honored to have you, sir. So not
Thank you.
taking much more time, sir. We are just handing over the session to Dr. Vish Prakash for his insightful learning. Thank you, sir. Over to you, sir.
Thank you. Okay, today we will discuss the IL-17 cytokines and biology of IL-17. Actually, it's the most interesting cytokine among whatever. Actually, it's the most important cytokine and it involved in some rheumatological diseases like spondyloarthritis group, ankylosing spondylitis, psoriatic arthritis, IBD-related arthritis, inflammatory bowel diseases. These sexes are there. So this is very interesting cytokine. And we know the various T helper cells. So IL-17 is secreted mostly known by the Th17 cell. So this is not fully true. Let's see regarding the IL-17. So first we have to understand the T cell activation because we are reading for the Th17. Okay. So we know the T cell develop initially in a thymus from the double negative stage. Double negative stage means CD4 negative, CD8 negative. Then subsequently during the development, we have CD4 and CD or CD8 positive T cells. So these are from the thymus, then these T cells, either CD4 or CD8, they goes outside and mature in the secondary in the lymphoid organs like lymph node and spleen. So this T cells got education from the antigen presenting cell. For that need to be the MHC2. Okay, the first antigen presenting cells takes the antigen, then they process it in the lysosome, then chop it, then this antigen is loaded on the MHC2 and then presented to the T cell. This is known as signal 1. Then the co-stimulation, once the T cell becomes activated, partially activated, they start expressing the co-stimulatory molecule CD28, which binds to the co-stimulatory molecule from the antigen presenting cell ligand CD8086. That is called signal 2. That is known as co-stimulation. So T cells got a signal 1, signal 2, then find the signal 3, which is a polarizer of this T cell, CD4 cell. So CD4 means T helper cells. So on the basis of the polarizing cytokine, this T helper cell convert into the Th1 or Th2 or Th17 or T regulator or many more different T cells. So this is a T cell activation. One of the T cell is a T helper 17 cells. So we have to know everything about the T helper 17. Which cytokines involved in the polarization of this T helper to T helper 17 is very important. Okay. So let's do once again the polarization of the CD4 cell, that is a T helper cell, which is important, very important. Suppose the antigen presenting cell present the antigen to the CD4 cell and they start secreting IL-12 or interferon gamma. So suppose there is an intracellular bacteria. That intracellular bacteria presented through antigen presenting cell through MHC2 to the CD4 T helper cell, and antigen presenting cell start secreting IL-12 or interferon gamma. Then this T helper cell convert into the T helper 1. So polarizing cytokine is IL-12 or interferon gamma. Master gene regulator, once interferon gamma or IL-2 comes in a contact with the naive T cell, they start forming the gene regulator that is a T bit. So with the helper of a T bit, this naive T helper convert to the T helper 1. T helper 1 secretes TNF alpha, IL-2 interferon gamma. So major role is intracellular pathogen clearance, like tuberculosis. Okay. Suppose antigen presenting cell presenting to the naive T cell, this time antigen is an extracellular fungus or extracellular gram negative bacteria. So the antigen presenting cell starts secreting some combination of a cytokine like IL-6, IL-1 beta, IL-23, TGF beta. So cell converted into T helper 17. So polarizing cytokines are this. Master gene regulator, this is very important. Gene regulator is ROR gamma T. This is a retinoic acid orphan receptor. So once the ROR gamma T activated, they convert T helper into T helper 17. So they start secreting IL-17. There are many ligands of IL-17 and many receptors of IL-17. We will see. Major function, they recruit the neutrophils. They do the barrier function in the different lumens. They protect against the extracellular bacteria and fungus. So these two arms are the cellular arm. TH1, TH17, gene regulator, T bit here. Here raw gamma T. Some combination of cytokine IL-12. Here combination of cytokine along with IL-23. This is polarizing cytokine important. Suppose some helminth or allergen is here. Then the antigen presenting cell after the presentation to the naive T cell, they start secreting IL-4. So IL-4 through the GATA-3, they convert into the T helper 2. So T helper 2 effector cytokines are different and they help in the allergy. They help in to defense against the extracellular parasite, and overactivation leads to the different allergic processes. And suppose there is a persistent antigen stimulation and cytokine is IL-6, IL-21 or ICOS ligand, then the T helper cell converted into T follicular cells. So for the T follicular, master gene regulator is BCL6. Master gene regulator for the TS2 is GATA3. Say they start secreting, acting the B cell, and B cells start secreting antibodies. So this left hand side we have the humoral arm. TH2 for the IgE, T follicular for the IgG and different antibodies. Here TH1 for the intracellular, here TH17 for the extracellular. Suppose body wants to get rid of all these immune cells because of overstimulation. Once infection is out, then the antigen presenting cell starts secreting anti-inflammatory cytokine like TGF beta along with the IL-2. They converted into the T regulator. FOXP3 is a master gene regulator, which secrete the IL-10. So IL-10 inhibit the TH1, IL-35 which inhibit the TH17, TGF beta which inhibit the uh, TH2 and all these pathways. So these are the important T cells. So we have to focus on the TH17. Okay. So as we understand, T cell converted into the different phenotype on the basis of the cytokines. So suppose we can divide the polarizing cytokines into two parts, inflammatory cytokines, anti-inflammatory cytokines. Suppose there is a combination of anti-inflammatory cytokines like IL-6, IL-1 beta, IL-23, then the cell will be converted to the TH17. If it is IL-12 interferon gamma TH1, IL-21 or T follicular helper. Same here, if anti-inflammatory cytokines like IL-10, TGF beta, then the result will be the T regulator cells. Anti-inflammatory cytokines like IL-4, 13, then T helper 2. Then this is a tissue resident T cells. Suppose TGF beta is there, then there are the tissue resident T cells. So important thing is that for the formation of the TH17, we need cytokines. What cytokines? Combination of inflammatory cytokines and anti-inflammatory cytokines. That cytokines leads to the TH17 polarization, and TH17 cells start secreting TH17, which is a which is a chemoattractant for the neutrophils and inflammatory cytokines. Okay. So the role of the IL-17, why we are reading the IL-17? Because this is important in the spondyloarthritis group. So we understood first innate immune activation that leads to the dendritic cells to secretes the IL-23. IL-23 receptor not only present on the T cell, they are also present on the non-MHC restricted cells like gamma delta, mate cell, mucosal associated invariant T cells, ILC3. ILC3 is like TH17. ILC means innate like lymphocytes. So innate lymphocytes like one for TH1, two is for TH2, and three for TH17. Even neutrophils. So all these cells have IL-23 receptors. So all these cells can secrete IL-17. Important is if this is either MHC restricted or non-MHC restricted. So there is not only TH17 cell which is secreting IL-17. IL-17 can be secreted by the different other cells like gamma delta cell, mate cell, mucosal associated invariant cells. So important things are there. These cells are not present in the lymph node proper. They present in the different tissues. They are the tissue resident cells, like in the skin, like in respiratory tract, like in reproductive tract. So they can secrete from the local cell also. Action of the TH17. TH17 can recruit the neutrophils. They can cause the cartilage damage. They can stimulate the osteoclast, cause the bone erosions. So they can, because of the tissue residency, they can present on the enthesis. So they can involve in enthesitis. They can present on the bone osteitis. So different things are there. And they can interact with the TH17, and whole soul inflammation can be amplified. So this is why we are reading IL-17, because IL-17 is very important for the axial spondyloarthritis, peripheral spondyloarthritis, and for the derma, especially in the psoriasis. Why psoriasis is driven by the IL-17? Because there are some tissue resident T cells and non-T cells which can secrete IL-17 that can cause over psoriasis. What is requirement for the pathological or TH17 or IL-17 secretion? IL-23. Okay. So let's start how this TH17 concept or IL-17 concepts comes in the picture. 40 years back, Kaufman or Hoffman, there are two scientists. There was only concept of TH1 and TH2. So initially they think TH1 is for the granuloma and autoimmunity, TH2 for the allergy. So for the encephalitis model, what they did, because IL-12, because for the TH1 pathway, you need IL-12. That is clear. So IL-12 was made up of IL P2 units, P35 and P40 unit. So what they did, and once the IL-12 activate the TH1, there was the interferon gamma, or interferon gamma can be the TH1 pathway. They think only TH1 pathway can involve in the autoimmunity. So they blocked artificially interferon gamma, but autoimmunity was persisting. Despite of blocking interferon gamma, it was persisting. Then they blocked the P35 unit. It was again persisting. Once they blocked the P40, then autoimmunity was reduced. So what they think, what they understood, ki there was something which is present in IL-12 along with some other cytokine, which is creating this disease. So what they think, paradox, why does removing P40, inactivating IL-12 along with something is protective? Because P35 was not protective. Then the answer was the discovery of IL-23. IL-23 belongs to the IL-12 group. They're made of two units, P19 and P40. Because P40 unit was a common in both cytokine, so they able to block the autoimmunity. So IL-23 was involved in TH17. IL-12 was involved in TH1. So once they block that P40, so, autoimmunity stops. So conclusion, IL-23 was the culprit in autoimmune encephalitis rather than IL-12. Then birth of the TH17 cell. Then what happened? They in vitro, they took the naive T cell and gave the environment of TGF beta and IL-6. Once they gave the TGF beta and IL-6 through the ROR gamma T, TH17 developed. But there is a crux. Then fourth point come in 2003. Harrington et al. They show TH1 for the persistence of the TH17, there should be that IL-23 and TH17 is distinct. So there shows there is a distinct TH cell other than TH1 and TH2, which is expanded by the IL-23 that is known as TH17. So we come in the model of TH1, TH2, TH17 model. So initially we are reading with only TH1, TH2. Now TH1, TH2, TH17. So what is IL-23? Because if you want to create TH17 cell, TGF beta, one anti-inflammatory cytokine, and IL-6, that is sufficient. And this TH17 cell is for the tissue residence and for the local barrier function. Once you give IL-23, so IL-23 does not initiate the TH17 differentiation efficiently. Instead, they enhance the survival. They induces the pathological TH17 cells. So pathological TH17 cell, how will you know? Once the TH70 cells start secreting GM-CSF, that is granulocyte monocyte colony stimulating factor, that is pathological TH17. So we have two type of TH17, that is physiological or homeostatic and pathological. Physiological, once you have only combination of inflammatory and anti-inflammatory cytokine. This is TGF beta and IL-6. IL-6 means inflammatory cytokines. TGF beta is anti-inflammatory cytokines. But once you add the IL-20 in, then there is amplification of TH17. So important thing is IL-23 leads to the pathological TH17. That is one. Second, IL-23 also secretes the IL-17 from the different T cells, the different cells other than the TH17. What I have shown now, we will discuss later also. So again, see the differentiation pathway. Only suppose TGF beta is there, then the cell will be converted to the induced T regulator cell. But along with the TGF beta, if you give IL-6, it will convert it into TH17. But once you give the inflammatory malleoli plus, that is either IL-1 beta, IL-23, then it will convert into the TH17 pathway. And all these things are there. So there is two type of TH17 cell, homeostatic that are non-pathogenic. They are secreting anti-inflammatory IL-10. And there is a pathogenic IL-17. They are secreting a GM-CSF, which is a myeloid attractor, interferon gamma, and this is IL-23 dependent pathway. Okay. Second. So IL-17 family, they have five ligands, IL-A to F. Main is A and F. That is important for the spondyloarthritis and psoriasis group also. And we have C and E. E is for the epithelial cell, and that induces the TH17 pathway. That is important. Okay. Then the IL-17 work through its receptor. The downstream pathway is not JAK. That is important. Downstream pathway is ACT. So IL-17 is not working through JAK, but IL-17 is secreted by the IL-23 or IL-6, which is act through JAK. That's why JAK inhibitor comes here. So IL-7, this is a different IL-17 no, molecule. So IL-17 is an important molecule in rheumatology. A and F act on the same receptor. So they are important. C and E have the distinct role in type 2 or allergic immunity. So these are the there. Cell differentiation. I told you antigen presentation, then on the basis of the different cytokines, cell differentiated. But let's see isolated TH17. Initiation by the two cytokines, TGF beta and IL-6. Inflammation licensing, once they got the any inflammatory cytokine like IL-1 beta or TNF, stabilizing the pathogenic molecule IL-23, amplification, auto amplification through IL-21 or IL-6. These are the different cells. So, and which transcription factor is important? RAR gamma T. RAR gamma T chromosome is third. This is not only important for the differentiation of the TH17, they are important for the other cell differentiation which are capable to secrete the TH17. Then there is RAR gamma T it has gone through very epigenetic phenomena. So in epigenetic phenomena, once suppose it is close, obviously methylation, deacetylation. Once this is demethylate or histone deacetylate, they start their secretions. So differentiation has two types of the cells, non-pathogenic or pathogenic T cells. Epigenetic molecules has been through the metabolic reprogramming. Because in the down the lecture, I will explain why psoriasis is a metabolic disorder and why obesity leads to more autoinflammation. Okay. Then it has some barrier function and all those things. So subset, TH17 subset. We will discuss regarding a TH17 subsets also because TH17 is very plastic cell. So this is two cells, homeostatic, pathogenic. Homeostatic, they are mainly for the barrier functions. Our gut is normal functioning through homeostatic TH17. So suppose your homeostatic TH17 is not working properly, then you will have inflammatory bowel diseases or Behçet diseases. That's why IL-17 inhibitors sometimes can leads to the aggravation of Crohn's disease. So they are the for the barrier function where gut, lungs, skin, reproductive tract. Inducing cytokine. you need to have an anti-inflammatory cytokine for here. That is TGF beta, along with all these things. Here you need only inflammatory cytokines with or without or low TGF beta. So IL-1, IL-6, IL-1 beta, IL-23. So crux point is that if you have an inflammatory cytokine malignant predominantly, then the conversion will be towards TH17. If TGF beta is there, then it is TH homeostatic. IL-23 dependence. IL-23 is important for pathogenic TH17 cells. Cytokine profile, they will have low GM-CSF. They will have high GM-CSF along with TNF alpha, along with interferon gamma. Function, they have barrier function. Here, function, neutrophilic recruitment, tissue inflammation, osteoclastogenesis. Metabolic profile, we will discuss metabolic profile soon. Transcription factor, here you have HR high. HR high means aryl hydrocarbon receptor high. Then here you have more STAT3. So ROR gamma T is important for both homeostatic and pathogenic T cell. But STAT3, more STAT3 will lead to the pathogenic TH17. More aryl hydrocarbon will lead to the homeostatic T cell. Then these are the homeostatic overall, and these are the inflammatory. So if you have an inflammatory maluli, like most common IL-1, IL-6, IL-23, TNF alpha, then it's a pathogenic. And if it is a pathogenic, then GM-CSF will be high. Okay. So there are this, then we will see the plasticity, what we are discussing. So once we convert here again, naive cell committed TH17, that is homeostatic, that can convert into the pathogenic T cell. Pathogenic TH17 can convert into the XTH17, that is converted. Let's see. Suppose only IL-23 is there, then this is a pathogenic T cell. Suppose this T cell start getting function, getting signals from the IL-12 also, then this is known as XTH17. XTH17 will cell will be TH17, but they will secrete interferon gamma more. So in rheumatoid arthritis, there is a TH17 cell, but that is actually XTH17. That TH17 has been converted like TH1. So they behave like a TH1. Yeah, if inflammatory cytokine is IL-1 beta, then again inflammatory, then IL-6, then it can convert into the T follicular helper type also. So TH17 can behave like a TH1 also, or T follicular helper. Suppose it behave like a TH follicular helper, then it can help in the formation of antibodies. That's why in pathogenesis of SLE, even in ANCA vasculitis, you will get somewhere TH17 pathway, because it is another type of TH17 which can stimulate the B cell. Then this, suppose there is a TGF beta. So you can have tissue resident, means not only the lymphocyte. Now the TH17 cell will go in somewhere and sit in some tissue, and then that will become tissue resident TH17 cells. Okay. So major plasticity. So TH17 can convert it into TH1 like. TH1 like means total IL-17 loss, gain of interferon gamma GM-CSF. That is common in rheumatoid arthritis. That's why this inhibition does not leads to work. Then TH1 like, then T follicular helper, I told you, suppose persistent IL-6, IL-21 is there, then the BCL6 transcription factor, like here TBET. So they behave like a T follicular helper. T follicular helper will help to the B cell. B cell promotes the antibody production that can be the pathogenetically involved in SLE in RA. Then tissue resident memory, that is very important, because TH17, we are discussing the T cell. T cell is not educating in the lymph node. They are educating in the some tissue, normal tissue. They are living their long lived like in enthesis. They call tissue resident T cell. Suppose there is an anti-inflammatory cytokine, so they will resident tissue resident T helper resident tissue cells. So they will start creating the fibrosis in the enthesis that leads to the enthesitis. Then suppose even T regulator cells can convert it to the TH17 if there is an inflammatory moduli. So transcription factor is important, epigenetic factor, inflammatory moduli, all these things. So let's see the relevance of the plasticity of TH17 is different cell. In rheumatoid arthritis, what kind of TH17 cell? TH17 XTH17.1 cell, TH1 like behaving TH17, ankylosis spondylitis, tissue resident TH17 cell, or XTH17 cell which are secreting not only IL-17, although also TNF alpha. Psoriasis we are having pathogenic TH17, excessive IL-17, or tissue resident TH17 cell. In inflammatory bowel disease, we don't have physiological TH17. We are having the pathological TH17 there. So the means actually T regulator cells converted into TH17. Then in SLE, TH17 we have like a T follicular helper cells. So take home message for the here. This is there. TH17 cells are highly plastic. They are not terminally differentiated. They can convert on the basis of the inflammatory flow line. The plastic conversion drives the chronicity. Suppose TH17 convert into the tissue resident TH17, then the cell disease will become very chronic and resistant to the treatment from TH17. Therapeutic targeted. Suppose there is a pathological pathway, then you can block IL-23 or GM-CSF. So, and we will see the metabolism also. So, what is important among the T cells? Na? So IL-23 excess is a real pathogenic engine. So, once you have IL-23, that will lead to the pathological Th17. Pathological Th17 will secrete that IL-17A and F, that is a major IL-17. Then GM-CSF, they can secrete the TNF alpha and IL-22. IL-22 have a mucosal barrier function. TNF alpha has a augmentary action along with IL-17. IL-23 works through JAK pathway, that is a JAK2 and TYK2. Okay, IL-17 is not working JAK pathway, that is working through ACT pathway. This is there. So IL-23 is important for not for the conversion of TH17, for the stabilization, expansion, survival, pathogenic programming, and memory and persistent. And other than the T helper cell, IL-23 can convert other cells, can stimulate other cells for secreting TH17. So let's compare 12 and 23. 12 subunit is 3540, here 19 and 40. We will discuss it later. So whole soul IL-23 is important in psoriasis, psoriatic arthritis, and callus spondylitis, inflammatory bowel diseases. Subset of one subset is rheumatoid arthritis, even in SLE, even in giant cell arthritis. They are trying for giant cell arthritis also. So and this is important, metabolic pathway. Some because epigenetics is important, so some metabolic changes can lead to the pathological TH17 or homeostatic TH17. Suppose you are using more oxidative aerobic glycolysis, that is a Warburg effect. With oxygen, we are using glycolysis, glutaminolysis. We are making from the glycolysis lactate. So lactate hypoxic inducible factor, they are stabilizing the ROR gamma T and start secreting pathological TH17 cytokine like TH, IL-17, GM-CSF, all these things. So more glucose and more fatty diet is for the pathological TH cell, but oxidative phosphorylation of fatty oxygen leads to the homeostatic. So if you are having more fatty diet or glucose diet, you will have the pathological TH17. Suppose you are using it, you are on the keto diet or you are burning your fat, so you are having more towards the TH17. So this metabolic pathway is important. So simply homeostatic, you need the fatty acid oxidation or oxidative phosphorylation. Here you need for the glycolysis or glutaminolysis. Okay, all these things are so metabolically, just simple thing, more energy state, TH7 pathological TH17, less energy state, homeostatic TH17 pathway. Then microbiota is important. Microbiota, some diet, antibiotic leads to change your gut microbiota. In your gut microbiota, let's see the driving signal for the TH17 homeostatic TH17 pathway. If you have segmented filamentous bacteria like Clostridium, then you will have more inducer TH17. If you have short chain fatty acid like butyrate, propionate, you will have more homeostatic TH17. Bile acid on the basis of the context. Polysaccharide limits the pathogenic TH17. Tryptophan promotes the mucosal or protective barrier. So tryptophan is good. Short chain fatty acid is good, like propionate or butyrate. You need a polysaccharide is good, but peptidoglycan can lead to the pathological TH. So homeostatic TH17 means mucosal barrier is for the short chain fatty acid, polysaccharide, aryl hydrocarbon ligand. For pathological, you need segmented filamentous bacteria. So one other thing is a dysbiosis. Well, once there is a dysbiosis, this dysbiosis leads to the pathological TH17. Why pathological TH17? This dysbiosis also leads to the increased IL-23 and IL-1 beta. So consequences is all of this. So, therapeutic target. Now, we can use prebiotics. Prebiotics means in which your normal gut bacteria is living on, like fiber or resistant starch. Or probiotics. Probiotics means directly microbiota, like lactobacillus, like bifidobacterium, like Facialis bacterium. Probiotics, now postbiotics. What these bacteria is making? Short chain fatty acid, polysaccharides. Then dietary interventions like Mediterranean diet. So this diet is important for your normal gut health, because this bad gut health leads to bad TH17. Gut health leads to the good TH17. Bad metabolism can lead to the bad TH17. Good metabolism leads to the good TH17. So these are the pathway. Then regulation, same thing is there. TH17 can convert it into a T regulator cell, or T regulator cell in an inflammatory medulla can convert into pathological T cells. Then tissue immunology. Why this is important? Normally, cytokines has their cytokine receptor on the immune cell, but the IL-17 has its receptor on non-immune cells also, like epithelial cell. That's why psoriasis. Fibroblast. That's why leads to the enthesitis. Endothelial cells can lead to the different scleroderma related disorders. Chondrocyte in spondyloarthritis group. Osteoblast, bone formation. Keratinocytes. Then psoriasis. So all these receptors, point is just for this slide, that receptors present on the skin. That's why psoriasis, gut. That's why inflammatory bowel diseases, lungs in asthma, joint in ankylosing spondylitis, RA, bone in osteoporosis. Osteominology, they can stimulate the bone reabsorption more. They can and they can lead to the bone formation also through IL-23. So they can lead to the osteoerosions, then osteoproliferation. Osteoerosions is more. That's why osteoporosis. So whole soul IL-23, then TH17 secreting cells, IL-17 that leads to the rankle formation through osteoblast. Osteoblast leads to the activation of the osteoclast. Osteoclast leads to the erosions, and erosion leads to the positive feedback towards the dendritic cells. Why IL-17 blocks leads to the different way. In plaque psoriasis, as I told you, IL-17 receptor present in the keratinocytes. It has excellent response in psoriasis. Psoriatic arthritis. Enthesis has IL-17, IL-23 receptors. Excellent. Ankylosing spondylitis, moderate to high. In rheumatoid arthritis, I told you there is a different type of TH17. That is a TH17.1, which more we have more like TH1. Inflammatory bowel diseases. I told you TH7, IL-17 also help in barrier functions. So if you give IL-17 inhibitor, it can leads to the your precipitation of inflammatory bowel diseases. In SLE, very low evidence. So whole soul clinical response for the psoriatic arthritis in spondyloarthritis group. Anyway, you can give this. In the disease patterns. So different roles, because in somewhere TH17 is predominant, like enthesitis, synovitis, vascular organ, and psoriasis. But in like RA, there is different type of ITH17. Even you see here myositis, scleroderma, Jogren also TH17 pathways there. Then I told you different sources of the IL-17. IL-17 is not only secreted by the T helper cell, he is not only by, from the MHC restricted cell. That's why this class 1 MHC molecule like HLA B27 or HLA B51, why T cells working here? Because T cells needs education from the MHC2, because we have different cells we have which has IL-23 receptors, like gamma delta T cells. Gamma delta T cells doesn't have MHC molecule. Innate like cells, ILC3. ILC3 is innate lymphoid cells. Innate lymphoid cell 3 has IL-23 receptor. Okay. Neutrophils can have IL-23 receptor. Mate cells means mucosals associated invariant T cells. They have IL-23 receptor. Even CD8 cells, natural killer cells, natural killer T cells. So there are different types of cells which can secrete the IL-17. That's why I that's why IL-17 inhibition is not working in everywhere, and why IL-17 is secreting in callous spondylitis or Behçet disease. Now come to the secukinumab. Secukinumab, KI, told you, it's a KI means anywhere you see the KI word, that is a cytokine inhibitor. So secukinumab is an interleukin 17A inhibitor. They blocks the interleukin 17A. So They inhibits both 17 and in interleukin 17 and A and F. So approved indication psoriasis, psoriatic arthritis, ankylosing spondylitis. Very limited efficacy in RA. It's not approved in RA. Dosing is 150 mg for psoriasis. We need a loading dose 0, 1, 2, 3, 4 weeks, then every 4 weeks. For psoriatic arthritis, we can give monthly basis also directly. What infections can occur after IL-17 inhibitor? I told you for extracellular bacteria and for the fungus, IL-17 is important. You can have candidal infections or some pharyngitis or headache. Which trial is for the secukinumab? For psoriatic arthritis, we have Future 1, 2, 3, Maximize and Access trial, and Measure and Prevent trial for the axial spondyloarthritis. So is indicated for the psoriatic arthritis and ankylosing spondylitis. It is working better in the peripheral spondyloarthritis group. So efficacy in psoriatic arthritis group, what are the domains? In peripheral arthritis, enthesitis, dactylitis, even skin, nail changes, and axial symptoms and structural progression. This is for the IL-17. Safety profile, upper respiratory tract infection, because gram-negative infection can occur. Nasopharyngitis, headache candidates, injection site reaction, mucocutaneous candidiasis, because IL-17 is important for the antifungal action. Ixekizumab is another IL-17 inhibitor, which is it is approved in the axial spondyloarthritis, psoriatic arthritis, psoriasis. Same indication is there. This is also working in different. Bimekizumab is a dual IL-17 inhibitor. They are blocking both IL-17 A and F both. B optimal trial is for the B complete trial. B optimal trial for the bimekizumab. Same side effects are there. Brodalumab is a IL-17 A receptor blocker. Brodalumab is not IL-17 blocker, so it will block the different receptor A and F. This is also approved for the same indications. Now come for the IL-23, because IL-23 is a upstream of IL-17 pathway. So you can block that P40, because IL-23 is made up of P19 and P40 unit. P40 unit, if you want to block, you can block both IL-12 and IL-23 pathway, means both TH1 and TH17 pathway. Drug is ustekinumab. Indication, its work in psoriasis, Crohn's disease, psoriatic arthritis, ulcerative colitis. I told you, IL-17 inhibitors can precipitate ulcerative colitis and Crohn's disease. IL-19 inhibitor will block only IL-23, IL-17 pathways. So there will be the no blockage of TH1 pathway. So less immunosuppression. Antibiotics of guselkumab, risankizumab, trinacizumab, mirikizumab. Indication psoriasis, psoriatic arthritis, mirikizumab for the ulcerative colitis. So ustekinumab, if weight is less than 100 kg, 45 mg, dose 90 mg is more than 100 kg weight is there. Trials no for the psoriatic arthritis, Summit trial for Phoenix 1 and 2 for the psoriasis. Dosing is like initially you have to give 3 doses, like 0 week, 4 week, 12 week, then followed by that once in a 12 week, once in a 3 month. This is for the ustekinumab. And this is for the risankizumab, trinacizumab, and guselkumab. So I am just want to tell you, for the psoriatic arthritis, risankizumab is approved, and guselkumab is strong evidence. Others are less evidence. Less evidence. And what are the new drugs? You can block oral inhibitor of the IL-23, that is known as receptor IL-23 receptor. That's why in the last you have RA, so Ecotrokinra, that is a IL-23 receptor inhibitor. TYK2 inhibitor, other than dicrovasitinib, you have jasocitinib. You can block the ROR gamma T. ROR gamma T will be still experimental. Nano antibodies, solokimab. Solokimab is inhibitor of the A and F. This is a nano antibody. Then we have bimekizumab also. Current questions are how this plasticity work through metabolism pathway. How can we prevent the disease progression? All these are the important current questions. Okay, thank you.
Hmm.
Hello.
Hello.
Please.
Yeah, sir.
Topic. Is there any question?
Yes, sir, sure, sir. Let me just check. So thank you so much, sir, for once again for this insightful session. And the topic, I must say, it was a bit very complex topic. And but the way you, I'm saying, sir, the way you break down such complex topics into such simpler forms, that is really appreciable, sir. And plus your slides also, we must say, the slides and the mode of your teaching, it is more like more pictorial, and more in the form of flowcharts. So I think it is quite understand easy to understand, and we really appreciate, sir, and thank you for this session, sir. So we'll just
Thank you.
open the sessions like for any questions. Uh, Let me just take, sir. Fine, sir. There are a few questions. Uh, so one is what is the balance between pro-inflammatory and anti-inflammatory cytokines, and why is it clinically important?
Actually, we have because inflammation is not bad. First thing, na? Inflammation is the body's protection. Uncontrolled inflammation is a problem. So body wants to fight. After the fight, body wants the cessation of that war. So there is two kind of cytokines. One will promote the inflammation, and then another will terminate that inflammation. That is known as anti-inflammatory cytokines. So we need the combination of both. If this combination is tilted towards the inflammatory cytokines, then you will have autoimmune diseases. Suppose anti-inflammatory cytokines is decreased due to some pathway or some reason, then again you will have autoimmune disease. Suppose your inflammatory cytokines are excessively low, then you will have immunosuppressive disorders, primary immunodeficiency disorders. Suppose your anti-inflammatory cytokines is too much, then you have your immunodeficiency disorders. So we need a balance of these two things, like a yin and yang, like a light and darkness. So we need a combination. Any misbalance between these two can lead to the any way, either towards the HIV way, means prototype of immunosuppression is HIV and prototype of autoimmunity is SLE. In both diseases, you will have multiple organ involvement, from head to toe. In HIV also, that is not HIV/AIDS actually. Once the HIV leads to that much immunosuppression, which is known as acquired immunodeficiency disorder. So acquired immunodeficiency disorder has from head to toe problem because of immunosuppression. Same SLE has head to toe problem because of autoimmune problem. So you can simplify that as anti-inflammatory melluli was much more in this HIV area, and inflammatory melluli was much more only in the autoimmune diseases.
Okay, thank you so much, sir.
Hmm.
So,
And for this question also, just one
yes.
minute, because in combination during the polarization, for the polarization, we can think like there are different kind of pulleys, na? TH1, TH2, TH17, different TH cells. For the polarization, you need a polarizer, different training. If you have a training of along with anti-inflammation also, so you know how to attack. That is known as homeostatic TH17. That is for the barrier function. That is for good for us because they want to fight against the pathological pathogen, but they will not create local problem. So no colitis, no GIT problem. But once you have only inflammatory cytokines, no anti-inflammatory cytokines, then this TH17 will become pathological. They will not only damage the bacteria, they will start damaging your cell also. So this combination is important. That's why some diet which is inflammatory can lead to the inflammatory TH17 cell. Some diet which is anti-inflammatory that leads to the anti-inflammatory TH17. Actually, TH17 is very vast and very interesting, and this is very recent and new. So this will explain why obesity is more with autoimmunity, because obesity can lead to more TH17. Why healthy life is more healthy means not autoimmune disease, because that is more homeostatic TH17. So these are the two plastic cells.
Okay, thank you, sir. One more question, sir. We like you to assist. Like, are there any biomarkers that indicate increased IL-23 pathway activity?
There are very biomarkers, like I told you, that is in the investigational level, but because any cytokine will work through some adapter molecule or some downstream molecule. So IL-23 is working through STAT3. IL-23, the downstream, there is a STAT3, one transcription factor is there. Second thing, you can second, lots of things are there like P40 unit, P19 unit. So different things are there where, but there at present there is no clinically available things through which we can assess the IL-23 biomarker, or it's because one way you can predict, huh? If IL-23 is there, then definitely there will be GM-CSF. GM-CSF is a molecule which you can measure. That is important for the neutrophilic infiltration. From basic biology, from 10, 11th, even 8th, the people know first cell is neutrophil. So TH17 is also behaving like that cell which is calling the neutrophil. So neutrophil is coming through colony stimulating factor. Some colonies are there. G for granulocyte, because neutrophils have different granules. That's why these cells are known as granulocyte. So a monocyte also has granules, and they develop from different things. So GM-CSF is a marker of IL-23. So there is, if suppose abscess are like psoriasis, very classical example. If dermatology fellows is there, they will understand. In histology of a psoriasis, once you see histology, then there is abscess. One scientist was Monroe. That's name known as Monroe abscess. Actually, that was neutrophil only. So which cytokine was calling that neutrophil on the skin for the persistent level? That was IL-17. Who instructing I for the secretion of IL-17? That was IL-23. So IL-23 calling IL-17, then GM-CSF. So all these three, this is not very complex, but it is not commercially available right now.
Okay. Okay, sir. Thank you so much, sir. And if there are any questions, I request everybody that they can just drop the questions in the chat box, and doctor will soon assist for the same. So with this, I think, doctor, uh,
Last two words, actually, I forgot while because lecture was little bit more along the immunological side. Clinical point, I just want to say, TNF inhibitor, there is a risk of TB reactivation because TH1 pathway is there, and that pathway secretes the TNF alpha. So if you inhibit the TNF alpha, chances of TB reactivation because it's an intracellular bacteria. But TH17 pathway means IL-17 inhibitor. There is a that is not involved in TB protection pathway. So IL-17 is not strongly associated with TB reactivation. That is one difference. So if you have a risk of TB reactivation, then choose IL-17. That is one. But TNF alpha is better than IL-17 for the clinical efficacy. That is one. Second, if patient has a family history of cancers, so TNF inhibitors are actually has a black box warning for cancers. So suppose patient is having some cancer or something. So TNF inhibitor can lead to the propagation of that cancer. But IL-17 is not having that problem. So IL-17 has two benefits over the TNF inhibitor. One is over other cancer conditions. Another thing, family history of cancer. Another other thing is TB history. And but clinically, TNF alpha is better. So these two things doctors should know in their mind. Suppose patient has a father has TB, mother has TB, family has full of the some environment or something, and you are giving TNF inhibitor, then patient is on the risk of TB reactivation or TB infection. Okay.
okay, sir. Thank you so much, sir. So if your permission is there, then we can
Okay.
just thank you once again, all the participants, and thank you, Dr. Vish Prakash, for giving us such in-depth explanation for the slides, for the questions. So we'll soon come up with the next session, probably on as per the doctor convenience, and I think in the coming, we'll just let you know when the next session is scheduled. So please be tuned, stay tuned, and thank you, doctor. Thank you, all the participants. I think we can close, doctor.